I have to admit, this is the most nerve-wracking part for me, is trying to get things running, but I think we're in good shape now. Okay, so what I'm going to talk about tonight is comes under the big topic of what are we missing? You know, we're all kind of tied up with other things right now, but it is important to note that there are still lots of other pathogens out there that can cause a lot of confusion. Okay, so I want to talk about a patient that came to our facility pretty much the end of June 2020. So think about where we were and what we were doing the end of June 2020. And so this is a male, 56 years old, previously healthy, quite athletic. The only condition he had to speak of was hyperlipidemia. However, he had developed shortness of breath, fevers, chills, and weakness that had lasted for 7 days. And he went to his primary care provider, who prescribed, supportive therapy, ibuprofen, some Gatorade, some Tylenol. However, his condition continued to progress. And on the 5th of July, he came to our emergency department, and he was actually quite ill. He had a temperature of 102. He had a heart rate of 130, a respiratory rate of 40, and his oxygen saturation was only 84%. So he was in very acute respiratory distress. And he did have to be intubated straight away and admitted up to the ICU. So given the environment at the time, a course of remdesivir and dexamethasone started, and he was also given some azithromycin and vancomycin for empiric antibiotic coverage. And I'm not pressing the right thing to make my slides go forward. So this is a couple of images for you to look at. Please disregard that little arrow on the left side. So what we have here is both the CT scan as well as a chest x-ray, and you can pretty clearly see that he's got some significant infiltrates bilaterally in both shots. So obviously he was having a great deal of problem trying to oxygenate. In terms of the laboratory findings, his white count was a little bit elevated at 13.3. His creatinine was concerning at 2.69, and it was felt that he had been dehydrated for a while because he's had this illness for about 2 weeks now. And so he was suffering from some acute kidney injury. His C-reactive protein quite high at over 400, indicative of systemic inflammation. And so when he was intubated, BAL was collected at that time, and it was submitted for every culture under the sun, so bacterial, fungal, and AFB. He also had a Legionnaire urinary antigen test performed, which was negative. And from this BAL sample, he had a respiratory pathogen panel run. He was obviously tested for COVID, Aspergillus antigen, and a whole slew of standalone PCRs that you see listed on the screen. Okay. So here are the results from the COVID testing. On the 1st of July, before he was admitted to the hospital, he had an NP swab tested for COVID, which was negative. On the 5th, when he came to the ED, he came and had another NP swab collected, which was negative for COVID. He also had a BAL collected, which was negative for COVID. On the 6th, he had another NP swab collected, which was negative for COVID. And then a couple of weeks after he recovered and was released from the hospital, he had another NP swab for COVID, which was, guess what, negative. In the midst of all of this, at the beginning of his illness, he also had serum drawn for IgG and IgM antibody to COVID, which was, guess what, negative. So clearly, this patient does not have COVID. Okay, so the first of our questions. Why are you confident in this COVID result? That was negative. Was it because both his PCR and his antibody tests are negative? Was it because the patient was tested 5 times and you got the same result every time? Was it because of all the NP samples were negative? Or was it the timing of the sample collection? So, Matt, how do you want to do this? So we just let people answer by chat?
Let's do chat, I guess, for this one.
Okay.
If you press the poll button at the bottom, you could bring up the questions.
The
polling's not there, and I think it must be because you're host, and maybe only as the host, maybe only you have, I don't know.
I gave the host to Jane. Do you have the poll button at the bottom?
I don't, because I'm running off
You
an
have
iPad.
to look under the more button
stuff.
or the little 3 dots. Sometimes it
More. Chat, meeting settings, virtual background, disconnect audio.
Okay. Yeah, let's do chat then for this one.
Okay, I'm going to go ahead and roll with this. So the correct answer is actually number 4, the timing of the sample collection. And so this gives me an opportunity to touch briefly upon some of the kinetics of what we know now of RNA expression and antibody expression in COVID-19. Remember that this story continues to evolve. So generally speaking, remember that we can detect COVID RNA generally 5 days before the onset of symptoms. And those RNA levels continue to rise, and they really peak at around days 10 to 14 past the onset of detectable symptoms. And this RNA level will start to drop off. So around day 20, that level will be below the level of detection of most assays. And of course, you know, this depends on the severity of disease in the individual. The problem is that we know that sometimes you can detect RNA up to 30, 40, 50, even 60 days after the onset of symptoms. And this can cause a lot of confusion when it comes to RNA testing. But generally speaking, after day 20, the patient's no longer considered infectious. And so the serologic response is pretty classic for a viral infection. You start to see generation of IgM, which peaks around day 10 to 14, and eventually is replaced by IgG at day 21. Remember, we still don't have a really good handle on how long the antibody response to COVID will last, nor do we have a good answer on if it's a neutralizing antibody response or not. So more to come on that. The other thing to keep in mind here is that our patient was actually at day 10 to 14 of his illness, and he was quite ill. So if he had had RNA present, it would have been, I think, very, very detectable. Another thing to remember here is that the assays for RNA that most of us are using, so these are all emergency use authorization approved by the FDA, they're actually quite good. These are all commercial assays, and they have over 95% sensitivity. So again, if RNA was present in this patient, we would have detected it, and we would not have needed 5 tests to do it. 1 would be just fine. Okay, so let's move to our next question. And this is an open-ended question, so you all can kind of think about what your favorite organism would be if it fits the clinical picture. So what's on your differential? What kind of viral pathogens might fit in here? What kind of bacterial and what kind of fungal pathogens? And we'll give you all a minute to bring up your personal favorites.
I see Kelly Thompson said bacterial. Do
Okay.
you want to narrow it down, Kelly?
Name a bug. Okay, so we're going to move on here. Considering, you know,
Question, Jane.
so, okay, so the question is, what does he do for a living? I don't know what he does for a living. Marie Claire, can you comment on that?
It's funny, actually, I don't know either, but I do know what he was doing when he potentially caught this infection, which we can talk about later because it's something I know.
Okay, so, you know, this is, in a way, it's sort of a nondescript clinical picture. I mean, he's quite ill. He's got pneumonia that came on, you know, pretty suddenly. So it could be a lot of things. Obviously, you know, COVID is right up there. You know, we could also consider something like flu or RSV, although June is really not quite the right time of the year for that. Other viral pathogens that you can see in the summertime, adenovirus and paraflu. Among the bacterial pathogens, obviously strep pneumo is a, you know, classic cause of pneumonia, but you might want to think of other atypicals like chlamydiophila or mycoplasma. Among the fungal pathogens, you know, things like cryptococcus, histoplasma, coccidioides, possibility, but again, you know, there's no really significant travel history here, nor is this individual immunosuppressed. Aspergillus could be a possibility, as well as pneumocystis, but again, in a person who is, you know, relatively healthy with no underlying issues, I think that would be lower on my list to think about. All right, so I can't get my animation to work, so I'm just going to give you the answer. What does this patient have? He has Legionella. So pneumonia due to Legionella pneumophila. We isolated this using buffered charcoal yeast extract agar, very classic, and then did the final identification by MALDI-TOF. So let's talk a little bit about Legionella. Remember, this is a gram-negative, very small coccobacilli. When looking at Legionella in specimens, sometimes you get these, you know, short little coccobacilli, but once you grow it on a plate, sometimes you get these longer, more filamentous, actually very delicate forms, but they are still true bacilli. Legionella, it's really faintly staining with gram stain, and you have to train your eyes and really look for it because it can be quite tricky. Legionella shows up very nicely with silver stain or even Morton starry, but those are stains generally reserved for the histology section, and we don't see a lot of them in micro. Of course, everybody knows that this is a very fastidious organism. It requires the BCYE agar in order to grow it. Other agars just won't allow it to grow very well. We'll talk more about culture in a minute. Numerous serotypes and numerous species of Legionella, but the ones that most often affect humans, obviously, are Pneumophila, Longbeachii, McDadii, and Dimophi. And there's also 15 different serogroups of Legionella pneumophila, which can affect the urinary antigen test, which we'll talk about in a minute. Now, Legionella is actually pretty fascinating because although it survives, you know, pretty well in water and soil, it also has a tendency to parasitize other organisms intracellularly. So it loves to live within free living amoeba, which is pretty ingenious. If you're going to be a good survivor as a bacteria, find a nice amoeba to hang out in, which will protect you and allow you to reproduce pretty, you know, without much trouble. Now, once this enters the human organism, what would be the analog to a free living amoeba? Well, alveolar macrophages work very, very well. So again, this gives you an idea of how this organism can be so successful in the respiratory tract. So the clinical presentation of Legionella has a couple of different forms. First of all, we have what's called Pontiac fever, which is actually a fairly mild presentation, and it's often associated with exposure to aerosols. So this is a mild flu-like illness, which is generally self-limited, although antibiotics are sometimes needed. But our particular patient, remember, he was quite ill. And so he had what we call full-blown legionellosis, which is characterized by that bacterial pneumonia, which you saw in the scans. And the fatality rate for legionellosis is actually pretty significant. Generally speaking, underlying conditions, chronic diseases, immunosuppression will increase the risk of severe disease. However, this patient didn't have any significant underlying conditions. So here's our last question for this section. For the majority of cases, what is the best method for diagnosis and confirmation of legionellosis? Is it serology for IgM and IgG? Is it culture plus microscopic morphology and fluorescence? Is it the use of a respiratory pathogen panel or whole genome sequencing? And I'll give you a moment to think about that. Okay, we will move on. So actually, the answer is culture. Culture is still considered the gold standard for confirmation. And, I mentioned the use of BCYE agar, but you need to keep in mind that what is a good agar to use is called BCYE alpha. And this is BCYE plus alpha ketoglutarate acid. And this chemical serves to really enhance the growth of Legionella. The downside of BCYE alpha, though, is that it will also support the growth of other organisms like Eikenella, like Pseudomonas, like Bacillus, and you can see how those could be confounders with a respiratory culture. Importantly, Francisella tularensis will also grow on BCYE alpha, and we certainly know that is a hazard in the laboratory. So, it's a bit of a trade-off on what type of media you want to use. Can you rule out these other organisms that can cause you problems? Another way to approach it is that BCYE alpha is actually not a selective media. You can add antibiotics such as anisomycin or vancomycin or polymyxin B to your BCYE alpha and make it more selective, but the downside of that is that you can also inhibit other species of Legionella. So I'm not sure if there is a perfect answer here, but I think it's really important for you to keep these little tidbits in mind when you're working up your BCYE plates. Now, if you take a plate with growth on it, BCYE plate with growth on it, and you shine it or you hold it under a woods lamp, so this is fluorescent light, Legionella pneumophila will fluoresce yellow-green, and it's actually quite striking. We've had this work really well in our lab. You should note, though, that not all species of Legionella do this. Various other species may or may not fluoresce. So again, you kind of have to have an idea in your mind what you're looking for and see what your tests tell you. I have on the screen here, this is a nice side-by-side of two isolates, Legionella pneumophila and Legionella mcdadii. And actually, you can see that they look quite different macroscopically. The pneumophilia is actually pretty mucoid when compared to the mcdadii. So again, little tidbits for you to keep in mind to help you with your identification. So in terms of confirmatory identification, our commercial biochemical system's really not helpful because Legionella is biochemically inert for the most part. So if you're using something like a MALDI-TOF system, it's really important to check your system database. In both FDA-approved systems, the Bruker and the Vitek MS, Legionella pneumophila is present, but other species of Legionella, which may be pathogenic in humans, may not be present. So you need to check that. There are standalone PCRs available that use the MIP gene as target, which are actually quite specific. However, they may not speciate different Legionellas for you because MIP is common to all Legionellas. Whole genome sequencing is a great tool. We've had the chance to send isolates to our friends at BPHL, have them help us with whole genome sequencing. And it's really not so much an identification tool, but it is a strain typing tool, which can be incredibly valuable to you if you're having to do some epidemiologic work. Okay, well, the first thing that people generally think of in the laboratory when you have Legionella is the Legionella urinary antigen. It is important to note that with the Bionex card that most of us use, it is only specific for Legionella pneumophilus serogroup 1. In patients who have serogroup 1 and they have severe disease, this is actually a really good test. Obviously, urine is easy to get. It's an easy test to do, and the sensitivity is excellent for those with severe disease. But in mild disease like Pontiac fever, the sensitivity of this test does drop off dramatically. And obviously, if you're looking at other serogroups other than serogroup 1, this test may be of very limited use for you. And I think that has some bearing on our particular case here, because remember, our patient was quite ill, but his Legionella urinary antigen was negative. Now, serology using paired sera, IgG and IgM, that's really not routinely performed, so it is of no diagnostic consequence in this case. Respiratory panels are kind of a two-edged sword. So obviously, these panels are quite good. They're very, very sensitive, very specific, but you really have to know what's on your panel. Not all respiratory pathogen panels have Legionella on them. So again, you need to check that carefully. The one big downside to the respiratory pathogen panel is that you're testing direct from specimen. You're not going to have an isolate available to you if you want to do further testing or if you need to do strain typing. Okay, so let's turn to treatment of legionellosis for the milder presentations like Pontiac fever. If antibiotics are warranted, empiric therapy like you might use for community-acquired pneumonia works fine, consisting of a macrolide or maybe a fluoroquinolone. In this particular case, this patient had full-blown Legionnaire's disease, so very severe disease. And in those cases, you really need to target your therapy. Levofloxacin or azithromycin is recommended by IDSA. And remember, this patient had gotten azithromycin empirically when he came to the ED. So that was a very, very good catch. And those courses of treatment may need to be as long as 10 days, depending on the severity of the disease. So this case actually came out very, very good considering how sick this individual was. He was extubated after 3 days. His steroids were tapered. His acute kidney injury cleared after some aggressive rehydration. Unfortunately, his exposure to Legionella pneumophila was not identified, and we didn't do any serotyping. His empiric antibiotics were sufficient. And the thing about this case was that the clinical services were really hung up on the COVID tests. I mean, they did test him 5 times, and they kept calling our lab, wanting to know why we had such a crummy test, because it should have been positive and it was negative. And so this is where you have the opportunity to ask your clinical staff, well, are you considering other pathogens? And what's important here is that don't forget about culture. We do have proteomic and genomic methods available to us, but sometimes you have to perform the classic culture, and it can be the very best method that you can do. So I wanted to bring up just a couple of things that are starting to rear their heads as we look at various disease states during this pandemic. And so even though the topic of this talk is thinking of things other than COVID, here are some case reports of Legionellosis and SARS-CoV-2 co-infection. And so this was a case of pretty much every risk factor that you could possibly think of. We have an older male. He's got an underlying chronic condition, diabetes. He had 2 plane trips, one to Egypt, one to Japan, and a cruise stuck him in the middle of those. So it was not a good situation. So this individual did develop the appropriate symptoms. His Legionella urinary antigen was positive. He was administered both azithromycin and ceftriaxone, but unfortunately he succumbed to SARS-CoV-2, even though it was felt that his Legionellosis was adequately treated with antibiotics. So again, we may start to see co-infections of SARS and other things. And again, here's some additional case reports. So COVID plus flu, COVID plus paraflu, COVID plus metapneumovirus. So I think we're going to see a lot of confounding cases as we start moving through the winter with both bacterial and viral pathogens. So just something else to keep our eyes on. And I know there is a lot of activity going on right now doing concurrent flu and COVID testing. Also, RSV is in the mix too. But I will say, from our perspective, we have seen no cases of flu or RSV yet this year. So that's a good thing. And also, thank you, Diana, COVID with Aspergillus fumigatus. So that's something else to keep an eye on. Now, this is a little bit different. So here's a case report of a Legionella infection in a dishwasher. Now, remember that, earlier this year, March, April, Italy went through that very extensive shutdown. I mean, whole cities were shut down. And in this case, the building in which the dishwasher worked had actually been completely closed up for 3 months. And so after they reopened, this individual became quite ill with Legionella 3 days after he returned to work. And so it was determined that when this building was shut down, when you have these large industrial buildings, you really still have to maintain water systems, even though the rest of your building is completely shuttered. And you have to do water flushing, you have to do chlorination, you have to heat the water in the pipes. If you don't do that, you run the risk of building up Legionella, which can then become aerosolized and infective when that building becomes opened back up. So again, this may have some bearing on buildings in the US. We had a lot of buildings that were completely shut down for a period of time, and hopefully not, but we may be facing that again. And so we just need to be mindful of thinking about Legionella, especially when we have these cases of buildings that may be opened and closed. So with that, I'm going to wrap this up, and I just want everybody to think about, remember the days before. So remember, not COVID. We do have to consider other pathogens that cause atypical pneumonias, fungal, viral, bacterial. Right now, we are very concerned about co-infections of COVID and flu and RSV, but again, so far so good with that. And we're spending a lot of time with COVID and flu testing. So if you are working with clinicians and you start to see test after test after test, COVID tests coming in on an individual patient, that might warrant an additional discussion with the provider. What are they looking for? Why are they so convinced COVID plays a part, even though you have multiple negative tests? And are they thinking about atypical pathogens? Respiratory pathogen panels, a good tool, but not necessarily helpful when it comes to Legionella. Check your panel. And at the end of the day, don't forget about culture. It's a tried and true method. And it certainly solved the puzzle for us here. So with that, I'll take any questions.
So Jane, this is Mary Claire. I was just going, whilst we're waiting for questions to come through, I don't know what this person does for a living, but they did go on a fishing trip for 5 days where they slept on board the boat. So they hypothesized that where the person actually contracted the infection was that the water system in the boat hadn't been effectively chlorinated.
Aha. That's very interesting. And I'm a little disappointed that we didn't serotype this.
You did send it to us, so we probably have a serotype, and I think we have a project at the Bureau of Public Health Labs where we're actually doing whole genome sequencing on Legionella. So I think
we did send it to you. That's
yeah,
right.
so I think we sequenced it as well, but I don't know. Kelly may not have the details at her fingertips right this second.
Yeah, I would have to look it up, but we definitely did it.
Oh, okay.
Yeah.
Okay, so I have a question. So the best scientific meeting I ever went to, I got to see the flu researchers and the staff, the strep pneumo researchers nearly get into a fist fight with each other over who caused more deaths in the 1918 pandemic. Are we seeing with COVID many secondary bacterial infections? I'm not hearing about them, but I'm not working in the hospital. Or is this really more of a if you get COVID, that's all you're generally dealing with?
I don't think we've seen that many co-infections. I mean, usually once these people come in and if they're really, really ill, they're going to get the kitchen sink thrown at them. They'll get the remdesivir, they're going to get Banco, they're going to get, every antibiotic under the sun. So we're not seeing a lot of co-infection, but that's, not saying that it certainly can happen.
I think an interesting thing is probably actually how certainly if it's deaths and stuff are actually being recorded, because someone maybe has COVID, essentially recovers from it, but there's damage to their lungs or whatever, and then they get pneumonia, but the death is probably still certified as a COVID-19 related death. So I wonder if we'll really be able to tease out diagnoses and deaths based on that.
And I have to agree with Jane. We haven't really seen a lot of co-infections, but we have a couple of patients who have been in-house since like March or April. And so we're seeing kind of the unintended consequences of them just being in the hospital for so long. So they are, now full of yeast and full of multi-drug resistant organisms.
Ugh. Okay, I'm going to stop sharing now. Ha.
Okay. Should I take control back or?
Go for it.
All right. All right, Marie Claire, you ready?
Okay, sorry, I had to press all the buttons. All right, can you see it?
Yes.
And you can hear me?
Yes.
Great, okay. So again, another case looking at what we're missing during the COVID-19 pandemic, and my talk titled A 2020 Reminder to Think TB. So many people may have actually seen this poster. It's a graphic that CDC developed in 1989. And it was a poster that was for healthcare providers to remind them to consider TB in their differential diagnosis. And especially important when you think about the US, where we have really low prevalence of TB, and that TB maybe isn't at the top of the differential diagnoses, especially when clinicians really don't see that many cases. But at least thinking TB and having that on the differential does avoid misdiagnoses, and also helps to assure a more timely diagnosis, treatment, and ultimately prevention of transmission and further disease. Here is just a summary of some of the World Health Organization's end TB strategies. So adopted by the World Health Assembly in 2014 was this NTB strategy. And since that time, the World TB Day themes have reflected this. So 2016 and 17, the slogan was Unite to End TB. 2018, Wanted Leaders for a TB-Free US. We Can Make History, NTB. And most recently, 2019 and 2020, It's Time to End TB. And you can see this nice graphic related to time on the right-hand side and this 2019 and 2020 slogan. So the goal is to eliminate TB. And what does TB elimination mean? Well, that means less than 1 case per 1 million persons. And if we compare that to the US, where we're, like I said, in a really low prevalence setting, the US currently sits at 2.7 cases per 100,000 persons. That was what was documented in 2019. So we really have a long way to go to reach this goal of TB elimination. But by 2030, they hope to reduce TB incidence by 80%, TB deaths by 90%, and reduce catastrophic costs for TB affected households. So in a nutshell, a drop in new cases, a drop in deaths, and reduced poverty are the 3 main action items being worked towards by the World Health Assembly and the World Health Organization. So what about thinking TB in the time of COVID? Let's go to our case. We have a gentleman that flew from Hunan province, which, as you can see on the map here, is right next to Hubei province, that was the epicenter of the COVID-19 outbreak when it first began, in, as far as we knew, in January 2020. And this gentleman got on a plane and flew to Florida, where he lives in Alachua County. And this was February 2020. So the person in this case study, Chinese-born US resident, as I said, returned to Alachua County. He'd actually been on a 3-week trip to Hunan province, and that's about 300 miles from Hubei. The patient developed sudden fever, chills, night sweats, myalgias, and actually he came to the emergency department about 10 days after returning, saying that he was concerned. I mean, I'm sure he had seen the news and everything. He was concerned about COVID-19 exposure. The patient was admitted, and the following day, OP, NP, sputum, urine, and stool samples were all sent to CDC for SARS-CoV-2 testing. So actually, the State Public Health Lab in Florida hadn't started doing SARS-CoV testing at that point. Our first tests were on Saturday, February 29th, a day that will be forever etched in my memory. And so at this point, because it was prior to that date, everything was just being sent straight to CDC if the person met the appropriate criteria as being suspected of potentially having COVID. And the patient was started on empirical antiretroviral therapy. But subsequently, the patient did report a history of family members with active TB. So what happened with lab testing? The bacterial culture was negative, HIV was negative, the SARS-CoV-2 testing at CDC came back negative. The respiratory panel performed at the hospital where the patient was admitted was also negative, but an interferon gamma release assay, IGRA, for TB was positive. The patient's fever persisted with a worsening non-productive cough, and a few days later, the patient developed pleurisy and a chest x-ray revealed a right pleural effusion. So repeat samples were collected for SARS-CoV-2 testing and sent to CDC because despite the positive IGRA, there was still a suspicion for COVID. And because they didn't want to move the patient out of quarantine, actually chest imaging was delayed by 2 days. And so you can see here how the pandemic and COVID and all of the intricacies of this initial part of the outbreak sort of ended up with a delay for this patient in diagnosis. But a CT scan did reveal a worsening right pleural effusion, and a thoracentesis was performed to evaluate the fluid. But actually what was interesting was right around this time, maybe just a couple of weeks before, a publication, I think it was like a preprint, had come out by Xi et al. From China, indicating that only 5% of reported cases of COVID-19 were actually associated with pleural effusions. And I think at this point, seeing that the clinicians determined that they really didn't think COVID was still on their differential diagnosis. So treatment was initiated with first-line TB drugs, and the antiretroviral treatment was discontinued. The patient was discharged with a diagnosis of TB. But a few days later, the patient reported that he felt worse since starting TB therapy, and he continued to have a dry cough and shortness of breath, especially on exertion. So first question for you, and I guess we'll just have you put it in the chat. Oh, let's go back, sorry. What is the possible reason for the patient's worsening condition? The patient has COVID-19 and the previous tests were false negatives. The patient has not taken the TB medications correctly. The patient has multi-drug resistant TB and the drugs being taken are not effective against that strain of TB, or the patient needs to wait several more days for the TB medications to be effective. Let me see if I can see the chat. Jane, my questions are too easy.
Yeah, looks like you have a lot of threes.
Yeah, and that's the right answer. I think as well, listening to Jane's presentation this evening about the timing of the tests, and and Jane saying that if a patient was symptomatic and you were doing this PCR testing, it really should be positive. So I think we know it's not COVID-19. And as many of you may know, with TB medications, patients are actually observed. It's called DOTS, or directly observed therapy. So the chances of patient not taking the medications correctly is limited there. And really the patient's condition shouldn't worsen when they start taking medications. So it is 3. All right. So multi-drug resistant TB. So the patient, as I said, had returned to the emergency department and had a repeat chest x-ray, which showed this reaccumulation of the right pleural effusion with some associated consolidation. And at this point, an isolate had grown and was sent to the state public health lab. And I see that Charisse asked, were family members also resistant to the same drugs? And actually I don't have, that's a great question, but I don't have that information. And I don't know if those patients were in, those family members were in China, because I know one of the big challenges with this kind of thing is often you don't get a great history from a patient, especially if those family members are residing in another country, and it's kind of hard to get good patient and family history. But that's a good question. I'm going to find out after this talk. So sent to the state public health lab, and in conclusion, the state public health lab was able to perform molecular testing which determined that this was multi-drug resistant TB, which means it was resistant to rifampin and isoniazid, 2 of the first line drugs for TB. And this guided clinicians to change to the appropriate therapy regimen. And actually there is currently a new regimen in the US, which it's only been used in 2020, and it consists of bedaquiline, pretomanid, and linezolid. And so this patient actually took this, and it's a much quicker regimen for multi-drug resistant TB. Quite often an MDR-TB regimen in the past may have been about 18 months, but by November of 2020, actually this patient had already successfully completed therapy. So I just wanted to talk a little bit about the importance of molecular testing and also being able to perform direct molecular testing. So what do I mean by that? I mean molecular testing that is performed directly on the specimen. So not waiting for the isolate to grow, but being able to do this testing directly on the sputum or BAL or whatever sample you get. So if we look at what's available out there, there's the Hologic Mycobacterium tuberculosis direct test, or the MTD. It detects TB and it is FDA approved for respiratory samples. We also have on the market the Gene Expert MTB RIF assay, which detects TB and also detects rifampin resistance. And I'll talk a little bit more about that later. That is FDA cleared for sputum samples. So, you know, there are some limitations there in that it is restricted to sputum unless the lab wishes to validate other specimen types. And of course, there are lab developed tests which can detect TB and even detect mutations associated with resistance if they are developed and verified in such a way. And you can also, with a lab developed test, obviously verify multiple specimen types, but then obviously puts a lot of the onus on the lab. So it's often not possible for smaller labs or labs with a smaller volume for this type of testing to really go down that road. Well, what about direct molecular testing for specifically looking at resistance? As I mentioned, there's the Gene Expert MTB RIF assay, and it only detects mutations associated with resistance to rifampin. But this is still a pretty good indicator of multi-drug resistant TB, which, as I said, is resistant to rifampin and isoniazid. And the reason being is that rifampin mono resistance is relatively rare. We sometimes at the state lab here see 1 or 2 cases a year, sometimes none. So seeing rifampin resistance is a good indicator of MDR-TB, and many clinicians will just treat it as MDR-TB if they see that rifampin resistance. Another option is the line probe assay from Hein Life Science, MTBDR+. This detects mutations associated with resistance to rifampin and isoniazid. So that really is able to detect MDR-TB. However, although it's CE marked in the European market, it isn't FDA approved for the US market. So it's sold as research use only and has to be verified as a lab developed test. And then, as I mentioned before, with direct molecular testing for detection of TB, lab developed tests can be, developed however the lab wants to detect multiple resistant targets, but requires obviously expertise in that lab and a certain volume to make it worthwhile to have such tests. So next question, what could have been done to improve the timely diagnosis of MDR-TB in this patient? If they had thought or think TB, perform molecular tests for the detection of TB, perform molecular tests for the detection of MDR-TB, improve diagnostics for detection of SARS-CoV-2 and other respiratory pathogens, or all of the above. I really need to make my questions much harder. But yeah, absolutely. I think all of those things could have contributed to a timelier diagnosis. And like I said, there were other kind of complicating factors where the patient was quarantined with a worry about COVID, and things like imaging were delayed because of that. And I mean, I also think this was about the timing of when this patient came into the emergency department, because it really was right at the beginning of, you know, everyone suddenly being worried about COVID. And so it was a little bit like, this person's been from China, they have these symptoms, it's got to be COVID. And so I think that is something that will be interesting when we look back at this pandemic, is sort of like how you become a little bit blinkered in this, because, you know, it's all we can think about and focus on. So I do understand that the availability of molecular testing isn't necessarily there in every lab, and that's just the reality, because some labs are either smaller, or they don't have the expertise, or their volume is small. And so in these situations, we always recommend sending to the jurisdictional public health lab, wherever that is in county, city, or state, because most public health labs do have additional capacity for TB testing. They can support phenotypic drug susceptibility testing, particularly for labs that perform less than 60 tests per year. And the other role that public health labs play is that they're able to then refer on from that lab to the CDC for specialized testing that's not available in the public health lab. So let's switch a little bit just at the end to talk about IGRA, because in this case, the positive IGRA was helpful versus a tuberculin skin test, because the patient was from a country where vaccination is given and where there's also high incidence of TB. And so if the patient had received a BCG vaccination, it would have been possible to have a positive TST, and the IGRA is able to differentiate between that. It does not pick up positives from persons who have had BCG vaccination. And you know, IGRA can be helpful in the diagnosis of active and latent TB infection, but it cannot distinguish between those two disease states. And I think that's an important point of note. So even when this person did have a positive IGRA back in, you know, in the beginning of the case, I can understand why clinicians may have thought, well, this person's from China. It's very possible they've been exposed to TB at some point in their lifetime. And so possibly they have latent TB infection, but we're still kind of focused on this diagnosis of COVID, as opposed to thinking that this person had gone from latent TB infection to active TB infection. And as I said, there with LTBI, if untreated, approximately 5 to 10% of people with LTBI go on to develop active disease in their lifetime, but it is also dependent on all kinds of other factors related to that person's immune status. So I wanted to share here this graphic from a publication by Madhupai et al. From 2016. And it really looks at the different tests. So you can see the tuberculin skin test, IGRA culture smear, whether the person's infectious and whether they have symptoms like throughout the spectrum of TB disease, where it's from latent TB infection to sort of a kind of a subclinical disease to active TB disease. And I think we always think of it as being like two states, sort of latent TB infection and active TB infection, rather than it being more of a sort of a sliding scale. And so I just wanted to highlight that here, because I do think if we really are going to move towards the goal of TB elimination, we have to think about it in that way. So the utilization of IGRA is recommended for certain populations and has advantages over the tuberculin skin test. The utilization of IGRA in a public health setting has improved testing for certain patient populations. For example, some of the transient patient populations, homeless persons, where they're unlikely to return for the skin test reading, and also helps in a more rapid identification of LTBI, linkage to care and treatment if appropriate. And just a couple of mentions about one, there are currently two assays on the US market for IGRA testing. One is the quantiferon assay QFT+, and the other is the T-spot. And a couple of changes relatively recently, well, in the last couple of years, is that the QFT Plus now has a single tube draw option, which certainly has its advantages for investigations, certainly of public health importance, or in certain patient populations, or if you're out in the field, like with the homeless populations in prisons and jails. And from the public health lab perspective, implementation of IGRA in a public health setting has been helpful for surveillance, since IGRA and in turn actually latent TB infection is not actually reportable in most states. So that data isn't being captured, and whereas if that testing is being done in the public health sector, we're able to capture data from IGRA testing. Okay, so when is it not recommended that IGRA be performed? For the diagnosis of active TB, for the diagnosis of latent TB in children under the age of 2, for occupational health programs, or in patients with higher risk of TB, such as from certain country of origin, congregate setting, or an immune compromising condition. At least I managed to do, oh, I was going to say one difficult question. Managing to stump you all. I've got 1s, 3s, 4s, 5s. I think everyone's like, yes, for the diagnosis of latent TB. So it's kind of a little bit of a trick question. So it can be used as a part of the diagnosis of active TB, but obviously cannot be used solely for the diagnosis of active TB. So it is usually, it can be used as part of that larger clinical picture. So it's like, okay, what is the clinical picture? What is the IGRA result? And then obviously, ideally, you have a smear microscopy, and obviously ultimately an isolate would be great, and then of course the molecular tests that I mentioned. Absolutely IGRA for the diagnosis of latent TB. It's currently not recommended in children children under the age of 2. The Red Book does recommend, however, IGRA testing for over the age of 2. You can use it in occupational health programs. That comes down to the that occupational health program and what they decide to do, whether it be TST or IGRA. One of the interesting things that I will mention, and the reason I put occupational health programs in there, is that the recent guidance from CDC and the American Thoracic Society is actually that healthcare institutions can determine when they would perform screening for TB in their healthcare professionals. So before, where it would have said that either IGRA or TST needed to be done annually, that is no longer recommended. And healthcare institutions with occupational health programs actually have to make their own risk-based assessment of when their staff should get tested. And it actually will reduce, I think, probably some false positives from serially testing healthcare providers with an IGRA. But it does put the onus on that healthcare institution to determine when to do it. And obviously, if the healthcare provider is someone who deals with TB patients all the time, you're still going to be wanting to annually, or more than annually, maybe twice a year, test those people. And the same probably can be said for lab personnel who are working with TB isolates and cultures. I think IGRA is useful in patients with higher risk of TB. They may be from, and also a couple of reasons why. One is that they may be from a country where BCG vaccination is given, and the IGRA, it does not confuse BCG vaccination with latent TB infection or active TB infection. It is helpful in things like homeless population or congregate setting, or any issues where there is a concern for the patient coming back to get the TST read. And there are also, some, I would also say there's kind of some quality improvements that are made in the IGRA, in the fact that the IGRA is performed in a laboratory setting compared to a TST, which is not, and so doesn't fall under the same quality assurance programs that are in place in a lab. So, despite consistent decrease in TB incidence, it's still not decreasing sufficiently enough to eliminate TB. And the TB elimination efforts really need to target LTBI to reach the goal. And I've just given a couple of papers there if you're interested to read a little bit more about some of the efforts within the US, not only to improve methods for detection, but also treatment of LTBI, and the CDC target of testing and treatment for LTBI. So in summary, we need to think TB, even in low prevalence settings, and need to consider all of the diagnostic tests at our fingertips, whether it be ordering an IGRA or the availability of direct molecular tests to determine exposure or disease status in a timely manner. Secondly, that referring of samples for TB testing, a lot of expertise for TB testing does actually reside in the public health laboratory setting. And so often the public health lab can provide that testing. And lastly, from the public health lab perspective, they really play a role in educating providers about the services that they provide, and that there are other resources. I think I mentioned that the public health labs can refer samples to CDC such as the infectious disease pathology branch and the molecular detection of drug resistance testing at CDC. And there are other resources there are 4 TB centers of excellence throughout the US. Florida is in the Southeast region, actually covered by the Southeastern National TB Center located at UF in Gainesville. And with that, I will say thank you to Suzanne, the BPHL lab director here in Jax, Betsy Jones, who's the supervisor of our TB section here, and of course my colleagues at SMTC and the Department of Health. And I've given a list of all of the citations there. So with that, I guess we could open it up to questions for Jane and myself. Hang on.
Any questions?
I believe there's a request for comments on the T-spot test.
Yeah, I saw that. I'm not, I guess, wanting me to comment. I don't have actually very much experience with T-spot. I know that there were initially comments that T-spot was more sensitive than the quantiferon, but I believe that some of those challenges have been addressed with the QFT Gold Plus when they added an additional tube with additional antigens that can be stimulated. So there's now a TB1 and a TB2 tube with different antigens in the quantiferon test. And I think they tried to, quantiferon tried to answer some of those issues with that. The other thing I'll say is that Diasorin has the Diasorin Liaison XL instrument, which actually uses a slightly different chemistry for detection than a regular EIA, and that is also meant to improve sensitivity, and they got FDA approved for the quantiferon assay on the Diasorin. So we're actually at the Bureau of Public Health Labs just about to get going with that. And then the other thing I will say, well, one of the other things that was a disadvantage of quantiferon versus T-spot was the single tube draw. And again, I think quantiferon tried to answer that with this single tube draw in a lithium heparin tube, although it does in the lab then still require you to aliquot from that single tube into the 4 tubes for the quantiferon Gold Plus assay. So there is an aliquoting process, but at least the collection can be simplified. Lastly, T-spot has been acquired by Quest. So I think it will be interesting to, I'm sure whatever Oxford Immunodiagnostic is still running it there, but so I don't know what the acquisition of it will mean. And that was about a year and a half ago or something, and really to me nothing's changed, but it was just an interesting thing.
Okay.
So Marie-Claire, that was a great presentation. That was a good review of things because we're all thinking about COVID. So from a public laboratory perspective, do you have any concerns that either efforts or funding or resources for TB testing and surveillance is being supplanted by COVID?
Definitely resources and are being diverted. Funding wise, hopefully things will stay pretty static. So I'm less concerned about that, but I think in terms of resources and personnel and focus, certainly those have been diverted. Even if we just look at the TB program within Florida, many of those people were, what's the word I'm trying to find, but they were, you know, having to go to different cities and work in different settings, not doing TB, just working on COVID. And even though most of those people are now back, you sort of wonder, well, what impact did that have? The other thing is our volume is greatly down, but, you know, and if we look at like the number, I think Betsy's on. I think I saw Betsy and she may have numbers. But if you just look at the number of tests we did, say in May 2019 versus the number of tests we did in May 2020, it's a big drop. But is that because there's less TB, or is it because people weren't accessing care? And it's probably, we're going to find out, but definitely a concern. And it's not just TB. I mean, that goes for STDs, all kinds of things.
Yeah. Any other questions? Well, with that, I just want to echo what Jane just said. These are both two excellent presentations. We thank you both, and really to give us a reminder not to be blinded by COVID, and we still have these other bugs to watch out for during this time and onward.